in for a treat. All right. Today we are in for a treat. We're going to be discussing carceral health and how it relates to public health. And we are blessed to have one of our esteemed faculty here, Dr. Taylor Neer. And we're also blessed to have 3 individuals from our Idaho Department of Corrections, Ms. Tina Transu, Ms. Jaime Calderon, and Ms. Diana Drake. And I will just allow each of our presenters to introduce themselves and just share a little bit about their backgrounds and interests before we dive deeper into discussion. I'll start it off with you, Dr. Neer.
Hi, everyone. I'm Taylor Neer, and I'm super excited to be here today. My background in carceral health revolves around health in Texas and Arkansas, because that's where I did most of my formal training on carceral health in North Carolina. But I am an Idaho native and now at Boise State University, and I'm excited to bring some of these experiences back to Idaho.
Thank you very much, Dr. Neer. Jaime.
Hi, everyone. I'm Jaime Calderon. I'm the Quality Assurance Manager for the Department of Corrections. I oversee the rehabilitative programs for prisons, as well as case management. And what that entails is the case managers facilitate the rehabilitative groups, as well as get the incarcerated folks ready for release when they go out to the community. And shout out to BSU. I am alum from BSU. I'll be speaking a little bit further about what happens when somebody comes to IDOC and the transition from them going back into the community.
Excellent. Thank you very much, Jaime. Tina.
Good afternoon. My name is Tina Transu. I'm Deputy Chief of Probation and Parole. In my role, all the community reentry centers fall underneath me, and I will be talking about the role of the community reentry center as well as reentry, and the SUD falls underneath me as well. I've been with IDOC for 3 years. I spent 15 years as a victim witness coordinator in our community, working for the Boise Police Department as well. And I serve on the board of directors for the Wasman Center. And so human rights are a big part of my professional life. And I feel really blessed to be working for a department that cares about the incarcerated individuals.
Well, thank you very much, Tina. And Dana.
So I'm Dana Drake. I'm the reentry manager. I have been with the Department of Corrections for 18 years. I actually got my start as an intern through Boise State University through the Criminal Justice Department. So started as an intern through education and then moved into case manager, program manager. And then I've been in this current role for about the last 2 years. So a lot of my experience comes from more of that institutional setting. These last 2 years, I've been very poised and positioned to really learn about that community supervision. What does it look like when they come into our community? And so I definitely have a passion for our people that we serve and just giving back and what that looks like. So I'll very much be coming from the reentry side of things today.
Excellent. Thank you very much, Dana. And just to our audience, particularly those who've just joined, please come equipped with questions. As each of our excellent panelists here share more about how carceral health relates to public health, we invite you to share questions, or either putting them within a chat and I'll be able to read those, or just coming off of mute to simply ask. We want this to be an engaging conversation here today. And so we're not going to have any, PowerPoints or anything like that. It's just going to be free flowing, and we're just going to share some information and provide an opportunity for our public health stakeholders to inquire and, just looking for a wonderful exchange of information. And on that note, to kick us off, Jaime, if you could just share a little bit about what you do and, in your opinion, how it relates to public health.
Yeah, one of the things I forgot to mention is I started with the Department of Corrections in 2011. I started as a case manager, again, helping facilitate classes and getting people ready for release. And then I was promoted to program manager, so I oversaw the case managers, and I've been in my current role of quality assurance manager now for about 2.5 years. And how incarceration might affect some of you guys, some of your folks, is when somebody comes into IDOC, one of the very first things that they do, no matter if they're male or female, is they go to one of two units. They go to one of the prisons. It's ISCI, that's local here, and there's for the males, and the females go to Pocatello Women's Correctional Center. And one of the first things that they do is they go through a receptive and diagnostic unit. So that they come there from county jail. They go there and they get assessed. One of the assessments that we use is the LSIR, level of service risk inventory revised. And with that assessment, we can determine what their needs, the risk, and some of the responsivity factors that we have to take into addressing some of their needs. So based on that, there's other assessments that we use, like the GAIN, to determine if they have a substance use a need, or like if they have some issues with substance use. Also, depending on their crime, we'll assign them different programs that they have to complete prior to being released on supervision. And during the RDU, this is about a 2 to 3 week process the whole time, is they also they are also screened for medical reasons. Sometimes individuals, this may be the very first time that they're going to a medical provider in a very long time for various reasons. Maybe insurance reasons, they didn't have that out in the community, or they just, didn't go to a medical provider. So they're screened for physical screenings, dental screenings, their vision, and then depending on that, they'll get different follow-up appointments that they have to go through. And then also all that information is recorded in a separate system that is private, so that it's protecting their confidentiality. And for, in accordance with HIPAA, there's some follow-up assessments that are, at that point made for them, depending on what their needs are. And then once they are through the RDU process, they also get classified at RDU. And what I mean by classified is they will be either minimum custody, medium custody, or close custody. And the RDU, what does that stand for? It starts for receptive diagnostic unit. And again, everybody that is incarcerated, no matter what, whether they're male or female, no matter what their crime is, they are screened at the receptive diagnostic unit. So once they are done with RDU and they're classified, we can either say, hey, you can go to a minimum custody facility, and that's based on the risk. And there's some different factors that go into contribute to that: their age, their crime, their proximity to release. Are they going to be incarcerated for 6 months? Are they going to be incarcerated for 10 years, for 25 years? And that's a whole nother level on the how long they're going to be incarcerated for. But those are some of the factors that contribute to what classification they would be. But then also medical reasons too. Like if somebody has a lot of medical issues, a lot of medical appointments that they're going to need, then we tend to keep those individuals here in the Boise area. And then the reason we do that is because the larger prisons are here in the Boise area, so they are staffed better medically and mental health wise as well. So they receive a mental health screening, and they at that point too they're classified with different diagnoses that they didn't know that they had. Maybe they have, whatever a mental health issue with them, and they might need, more clinical care than somebody that doesn't have that. So depending on all those factors, we can move people around to where they're going to be better suited. And one of the things that we always try to do is we always try to house individuals at the lowest restrictions possible. And if somebody's minimum custody, we do our very best to get them to a minimum custody facility so they can be around other individuals that are also classified like they are. But during the time that they're incarcerated, again, let's say if somebody has somebody's been in for a year or two, or it doesn't matter, right? They want to see a medical provider. We do have a formal process. They can go and they're all given during RDU. Another important factor that we talk about too is PREA, and that's the Prison Rape Elimination Act. So we educate our population on the Prison Rape Elimination Act, so letting them know, hey, this is what's acceptable and this is not what is acceptable, to make sure that they're safe. Safety is the utmost importance for Department of Corrections, both for the incarcerated individuals as well as staff. So we update them on PREA, again, Prison Rape Elimination Act. But if somebody wants to see a medical provider, there's a form that they go and they fill out and they say, I need to see a medical provider for whatever reason. They put that in, and then just like for us, there's a waiting period depending on when the provider is going to come next, and then they're put on a call out. And a call out is what a call out is. It's they get it's like on a monitor that throughout all the units, and it'll say, like, for example, it'll say, hey, Jaime, you have to report to this location to see, for medical, and that's all it says, because we don't want to say like what they're being seen for. And then once they're there, then that provider that they requested will come and get them and say, okay, let's check out your knee or your dental issues or whatever's happening with them. And then again, hopefully we try to resolve those issues there. But if there's a follow-up appointment needed, we do make all those follow-up appointments. And our prisons are equipped with professional individuals that are able to help them with whatever issue they have going on. Now, if it's a very severe issue that they have that they can't do themselves, we do have contracts with St. Al's, and then we could say, hey, this individual has something going on that we're not equipped to help. So then we make an appointment with St. Al's and we transport those individuals to St. Al's so that they can get the proper medical care that they need. And then we'll bring them back to the institution. And if we need to do that more than once, we will, so that the individuals get the best medical care that they possibly can, and they can get taken care of, of whatever's going on. So we continue to do that, take care of the medical issues as well as mental health issues. So there's 10 prisons in IDOC, and there's also 5 community reentry centers. And I'll let Tina go into the community reentry centers. They'll have kind of different requirements depending on what they're going to be doing. Some of our institutions, one of them in particular, is St. Anthony Work Camp, and that's in eastern Idaho. And when they go to that institution, a lot of their work is they go out and work in the community, and they come back, during when their shift is over. Now for that, there's more requirements. There's certain, because they're going to be away from the facility, usually those individuals don't have a lot of things going on medically. And the reason that we do that is, again, for their safety. So if they need some kind of a treatment so they don't injure themselves, they have certain requirements that they have to lift a certain amount of weight. They have to have different things so they can be out in the community and not need medical attention. And that's the only reason, is so that they can be taken care of medically if something was to happen. And then when they're incarcerated, again, they can work and they can have different jobs so that we can, they can build skills. So when they're released into the community, they have more jobs. We have the correctional industries, we have jobs in the community, jobs inside the prison that build skills so that they can use that when they get released. And during that time, they do program, like we have classes on substance abuse, we have classes on anger management, we have classes on thinking errors, like thinking for a change and letting them know that, thinking drives behavior. All the classes are evidence-based. The classes are CBI, which stands for Cognitive Behavioral Interventions. Once they complete all those classes, they usually will go to the Commission of Pardons and Parole. And the Commission of Pardons and Parole, they are who determines if somebody gets to be released into the community or not. And a lot of the things that they'll take into consideration is their crime, the seriousness of their crime, what they've done in their institutional behavior, like if they're getting in trouble or if they're not, or if they're doing well while incarcerated, as well as also we help them get released into the community by helping them sometimes get a job. We make sure that they have transitional housing, or that they have a safe place for them to go and be released on supervision. If they don't have somewhere where they can go, and like if they don't have a family member that they can be released to, we do have a whole process, and Dana can speak on that, on us helping them provide housing for them. When somebody is released, the case manager's job in the institutions is to make sure that they're ready for that release. Again, making sure that they completed all the classes they're supposed to, making sure that they have a ride when they're going to be, released, making sure that helping them get jobs and helping them be as successful as they can when they're released. Back on the medical side of that is, if somebody's taking any kind of medication, whether that's for a physical impairment or illness, or a treatment, or whether it's for mental health medication, is they are released with a 30-day supply of whatever meds they are currently on, as well as a 60-day prescription. So that means that, once they're out of those medications for those 30 days, they can go and get their medication refilled for another 30 days. So that's 60 days of medications that they are prepared for. And during that time, I won't speak to that much, but our probation and parole department also helps them when we have reentry specialists that help them get to see a medical provider or get to see some kind of a provider, so they can assess the individual and see if they still need those medications, whether that's for physical or mental health issues. And that on the medical side is kind of the prison side of the medical mental health issues.
Got it. Got it. I mean, thank you very much for that comprehensive overview. I definitely have a few questions that are coming to my mind, but definitely want to give your colleague Tina to share some things. And you guys, again, please feel free to put questions that you may have in the chat. And also, towards the end of our presentation here, we're just going to open up our microphone so you can ask questions there. But Tina, if you could share just like similar to Jaime, how, in your opinion, what you've done and how you do carceral health relating to public health and what we see here.
Sure, thank you very much. The question and answer portion is what I think we're all looking forward to the most. So briefly, my role in the community reentry centers, we have 5 community reentry centers across the state, and we're getting ready to build another one in Pocatello. Community reentry centers is really for the population that's at low risk, to kind of learn those skills and get what they need to reintegrate into the community. So a lot of things in the traditional prison settings that the residents kind of get done for them. The medicines get managed for them. There's somebody that distributes medications. One of the things in the reentry centers, they get medicines. Most of their medicines are KOP, keep on person. And so they learn medical management again before they re-enter the community. They also learn job skills. The expectation is within 30 days of coming to the center, they do job search and work in the community. The jobs are fair wages, so they can save up money. One of the challenges, and Dana will talk about a ton of challenges when re-entering the community, obviously money, and for those individuals that have been incarcerated for an extended period of time, learning how to operate in the work environment. Technology is ever changing, how that works, and the community reentry centers are kind of a soft place to come each night and not worry about the day-to-day living changes that they will encounter when they're back in the community. We also do programming in the CRCs. If somebody that hasn't been able to do that at the facility, we're working on bringing in financial education. Not everybody does a great job budgeting. I always tease that my son could benefit from class as well. And so making sure that we give all the tools, they shop in the community and budget, and there's certain items that they're allowed to have at the CRC. And so making budgetary decisions about what to spend money on and how much money to save. Generally, with our female population, we find more, they send more of their funds home to family, and kind of educating around saving money for yourself when you kind of re-enter the community. There's a ton of other information that I could share, but I kind of want to stop there and transition to Dana about re-entry. So we have tons of time for questions and answers.
Sounds good. Thank you, Tina. Dana.
Yeah, so I happened to see the chat about just an example of maybe what is some of the jobs that they do that are considered fair wages. So I don't know if you have some examples.
Your
of that.
eyes are so much better. I can't see. I can't see that.
You can relate so well.
So there's a variety of jobs. A lot of food service jobs. We have some residents that have their CDL, and a couple of do truck driving. There's good jobs like that in the facilities as well. The kind of the bigger companies like Giovanni employs a lot of residents over the periods of time when staffing was an issue for a lot of companies post-COVID. They benefited from hiring our workforce because it's secure labor. They have a ride every day. They show up every day. They're really invested in their savings. And so they also work in a couple of the meat packing plants, employ our residents. So there's a wide variety of employers. Sometimes we have small companies small businesses that maybe the owners or other employees have lived experience themselves, and they come to us and employ our residents, understanding that finding employment with a history of felony convictions can be challenging. And so if they can hire the individuals while they're still incarcerated, it benefits the company and it benefits the resident. I hope that answered the question.
Tina, nod. Thank you, Tina, and thank you, Adrian, for your question. Oh, well, Tina, we got another one for you. I'll read this one aloud. Is there a certain percentage of their wages that they are required to save while they enter as I got something blocking my screen here. Is there a certain percentage of their wages they're required to save while in the reentry center? If so, how is this enforced or tracked?
It's a great question, and Dana's been working on that. So the reentry centers are self-funded, so the residents pay to live there. And so 35% of their wages go to paying for everything that it takes to live in a facility, the food, the transportation. We're not able to force anybody to save their money, but we try very hard to have those conversations surrounding fines and restitution and fees and all the things that they're going to be responsible for that could impact their supervision once they get out. And so kind of touting the importance of having as much paid off before you enter the community is conversations we regularly have. But Dana's been working on initiatives to kind of foster like not a mandatory savings plan, but an encouraged savings plan.
Thank you, Tina, for addressing that. And Dana, we'll turn it over to you.
Yeah, and I'm just going to kind of bounce off of what she was saying before I kind of delve in. But Tina mentioned the financial literacy component of that, and I know that that is a hot topic right now. We have a lot of people, and what I mean by that is like we have a lot of partnerships that are going on right now that are requesting and wanting to come in and help our clientele and our population, which has been fantastic. I know Cap Ed, Mountain West Bank, Janice, I cannot think of how to say their name, but we have a lot of that going on. I think part of that is because the education department has also been looking at the financial literacy component. And so anyway, it's very exciting. It's been very much needed. So really just looking at how do we better help our population when it comes to savings plans and what that looks like. So anyway, I just wanted to, before I forgot that thought, I wanted to just mention that's definitely something that we're working on. I don't know how much it affects public health, but I mean, I guess if you don't have money, you don't take care of yourself. But all that to say,
social determinants of health, that's strong application. Absolutely.
Yeah. So just a little bit, I'm just going to talk a little bit about reentry specialists first. So reentry specialists, there's 11 reentry specialists across the state. They work out of the district offices. Department of Corrections has what's called 7 districts. They mirror health and welfare regions for the most part. There's a little bit of difference there. And so the reentry specialist position is really meant to help bridge that gap between prisons and the community. We're also finding there's a large need for jails in the community because we have a lot of people that are just put on supervision right at sentencing and maybe don't have the best, they were homeless prior to their crime. And so that reentry specialist position starts working with them prior to release and then continues that communication and interaction with them as they get out. They really do focus on our high medical, high mental health, also high risk individuals. So that's very much that public health portion of what you guys are talking about. Those reentry specialists come alongside those individuals to really help get some of this set up. And so I'm going to bounce off of kind of what Jaime was talking about with prisons and then what Tina was talking about for CRCs. So one of the huge things that has really helped us is the expanded Medicaid, right? So that allowed our folks to be able to actually begin to apply for Medicaid before they got out. The bummer part about a community reentry center is they make too much money usually. And so that's been something that I know the department is looking at, and Tina can speak to, what we're doing with that. But that's been it's a good thing that they're working, but it's become a little bit of a hindrance with the ability of maybe seeking medical attention when they get out. And I will say when they're in the community reentry center at this point in time, I believe that still the Idaho Department of Corrections is responsible for all of their medical needs. It isn't till they are officially released that shifts onto that next individual. So that has been a huge thing for us, is just that Medicaid expansion and being able to get folks on that Medicaid prior to getting out. Because you're talking about people that maybe did not have the best maybe habits or even being able to take care of themselves, just because maybe that addiction piece was so intense on that. So, I mean, I'll be honest, like I made some notes about barriers that we face and the things that we do to try to overcome them. But I feel like I've done enough talking for this moment. So I'll open, we have so much time. So I'll open it up to you.
Yeah, thank you very, very much. And your description perfectly dovetails. We have a great question in the comment in the chat here from Dr. Taves, an esteemed member of our Idaho community, our School of Public Health community for decades. And I had the pleasure and opportunity to sit alongside Dr. Taves as she chaired one of our thesis committees for our graduate students alongside Dr. Neer here. And it's just a perfect dovetailing with this question. And Taylor, I'll let you go ahead and expand upon this. But you know, looking about the importance of that transition, why Medicaid access is important for carceral individuals who are returning back to our communities. And Taylor, if you don't mind, you know, just addressing that along with any other things based upon your expertise, expert insights, both from our time on that thesis committee and just with your public service efforts relating to public health and carceral health.
Yeah, I think there's a lot of different things to address there, but I will try my best to do so succinctly. First of all, I'm really excited to hear all about what IDOC is doing. It sounds like there's a lot of great efforts there that I would say not every other state is working on. So it's really great to hear that Idaho has those goals and are working towards these efforts, because this population needs it. And we all, if you work in this area, they're part of your love, right? Like, I love working with this population. My background is specifically in jails, more specifically, just because of their pretrial detention, the quick turnaround times, and really we know that population is hugely impacted by the social determinants of health and their housing and their mental health status and substance use. So I worked specifically with helping individuals getting ready for release or needing help getting released in general because they couldn't make bail or different things, find the means that were within their community to help them upon reentry, so they didn't end up back in the jail system waiting for trial again, because it's a cyclical process. So we worked with a lot of community health workers, and ultimately the goal was to help get healthcare to a priority. But we know with hierarchy of needs, housing, food, financial means comes before any healthcare needs, right? But they all flow together. So that's really where I kind of fit in this picture, and that's where my background is. As for the Medicaid, obviously it's very important for these individuals to get access to care. That was one of the first things our community health workers helped individuals get, was figure out what insurance they could qualify and how to get it, and make sure it started before they were released. Because obviously once they're released, it's hard to find people that are in the jail system in the community and track them and help them at that point. So we would always meet with them the day that we knew they were going to get released to fill out all their paperwork and those types of things. But I know all those requirements are different per each state. So I worked in Arkansas, North Carolina, and Texas on these efforts. And then for the thesis component, we had our student conducted interviews with the 7 health districts to see what the health districts were doing upon reentry, and if they were interested in helping people upon reentry, what they could or couldn't do, and where they thought leadership was. And across the board, all the health districts were interested in learning more of how they could support reentry, but just not knowing where to start.
Thank you, Dr. Neer, and thank you to all of you. We see another question within the chat, which also dovetails to one of the questions I had slated for us. I'll read this out. Russ, thank you very much for sharing this. It states that in regard to transitioning to healthcare services in the community, are people referred to specific services for reproductive health, right? Thinking about sliding fee services, including the slide to $0 pay for contraceptive services as an example through through most of Idaho's public health districts. And so thinking about that question, but also tying here to some data I'd like to share with you here. As Dr. Neer mentioned, on that thesis committee, I've actually learned a lot in addition to advising our student. And one of the things that I learned that according to the most recent data from the U.S. Department of Justice, Idaho has the highest female imprisonment rate in the country, the highest of all 50 states. For every 100,000 residents, Idaho imprisons 137 women, which is 3 times that of Oregon at 43, and nearly 7 times that of Washington at 20. And so with this question on reproductive health, just would like to get your perceptions on 2 questions. Why is Idaho's female imprisonment rate so much higher compared to neighboring states? And 2, how does this disparity impact Idaho mothers and their children?
It's not always good to be number one, right? And so that's probably, we recognize that, and it saddens us. One of the contributing factors to that is Idaho has really strict drug laws, and as we know, our female population suffer a great deal of underlying trauma. Not to take away anything from our male population, but the female population certainly. We just tomorrow we start another phase of our gender responsive. It's called GRIPA, Gender Responsive Policy and Procedures Assessment. We're looking at gender responsivity in our facilities. We did probation and parole specifically to kind of dig deeper into how can we do better. If we know that we have a large number of women incarcerated, how can we serve that population better? And understanding that prisons were historically built for men, right? And so for years and years and years, the female population wore the same jumpsuits that were built for men, and the facilities were built for men. And so that doesn't necessarily go to the number of women we are incarcerating, but it's kind of goes to offering better treatment and conditions for the women incarcerated in Idaho. Also, we're in the planning phase of it's a new female prison, but it's going to look very different with much more of a treatment approach and a therapeutic environment than the traditional prison system. Women's health is really important to us. We have people, women that come into our prisons that are pregnant, and they give birth to babies in our prisons. And historically, that's not been very humane. And so we're taking steps. We're rewriting our policies and procedures to allow the women and child to spend more time together, for the women to have coaches and support in the room with them, for the babies to, have that time with their mothers. I know that I'm doing probably a horrible job answering the question, but it's really important that we first address the existing issues that we have inside our facilities as we bring mothers and children, and children into the world in an incarcerated environment. Also, we're more thoughtful about how we do reunification for those families that are fractured. Many times, sadly, we know that people who struggle through addiction alienate themselves from their loved ones sometimes, and they have fractured relationships, and that we know that support upon reentry is everything, right? Having healthy pro-social relationships and that family love and support is vital. So we work really hard to bring those relationships to people while they're still incarcerated. In the community reentry centers, we have a night in the female facility that the children can come in and do homework with their mothers. So the mothers kind of, I know that you know, when my son started doing calculus, I had to like dust off that part of my brain if it ever existed, right? And so the time to learn how to integrate and do homework and socialize with your children is sooner rather than later. And so bringing a lot of those things inside before our residents, especially our female population, have to figure it out upon reentry. I'm probably not doing a great job. My background is not medical, and so I'm not even certain what part of that question was.
You're doing an outstanding job. I can assure you. And it dovetails with some questions that I had, and like I think one of my top students, had, it shows why he was such an exceptional student within the course. Adrian, the first question that we had, just understanding from our public health connection, just understanding those first few moments, days, months, weeks, years of life, that skin to skin contact with the child. So you mentioned individuals may come to your facilities, women pregnant, and they give birth. Now they're curious, well, what happens next? Like what happens to the child? Is it adoption? Does it go to a relative? So if you can just, I'm sure every case isn't the same, but what happened?
Well, and I'm also not a lawyer, so I'm gonna play a lawyer now. So Idaho laws are fairly loose, as I know them. So you can kind of, as the mother, decide where your child goes without an in-depth look at that parental unit that you're giving your child to. And so we know that as a department, as we build this new facility, we're looking at the possibility of kind of doing I'm going to call it the wrong thing, but a maternity feature where the mother and child can stay together for an extended period of time. We've not decided what that period of time is. There are places where the mother and child can stay together for up to a year. And for, I think for most people, they recognize the need for that. Like you said, the skin contact immediately. And that's happening now in just not a sterile environment, but as much as we can, a loving environment. I know that many years ago, the women were, handcuffed to the bed. That is not happening anymore. And so we recognize that for the child and the woman, those first few hours are a lifetime footprint, right, if you will. And so we're doing everything that we can to make sure that we're not impeding that bonding that sets that child up for a lifetime of loving and nurturing.
Okay.
Yeah, and if I may too, so traditionally Idaho as a state, not this isn't IDOC speaking, this is just Idaho as a state has been, tough on crime, the war on drugs, and current as well as national politics come into play. One of the things that IDOC does not do though is we don't determine sentencing whether someone's found guilty or not. IDOC just houses those individuals once they've been found guilty. To the end, kind of going back to your question, it is a very sad reality. And we're all very we're trying to educate more individuals, and judges on hey, this is the impact of your sentences, so that they can take that information and best determine what they think is the best course of action, whether it's drug court, whether it's mental health court, whether it's just putting them on supervision instead of incarceration. We recently had one of our deputy chiefs, she's not here, deputy chiefs of prisons, her name's Liz Neville, speak to an audience of judges. I believe there was a lot of judges. I don't want to quote how many, but there was at least probably 50 or 60 judges there. And she spoke to the impact of what that does to the families, specifically to females and with children, and some of the things that we have that we can offer. She took some pictures of what it looks like for our visitation room, what we can offer, again, the children, so that we can better safeguard them. And at the end of the day, make the best decision for the individual that committed that crime, as well as their families. And it was very well received. One of the things that we try to do that, Tina was alluding to, is at one of our institutions, we recently had it was like a little if you would like a county fair, but it was like a little fair where there was toys, there was there was little booths that were set up, and families were able to come as a family with their children and basically have like a little fair, and the mothers got to go out and take the children out, and a lot of staff helped and volunteered on their own free time, or whether if they were on shift or not, they would be on shift, but some of them came and volunteered to help do some different things, some drawing, some paintings, like throwing, dunking people in tanks, just different little activities that so we don't use. So one of the things I want to point out too is, if you've noticed, we haven't used the word inmate or offender, because we believe very strong that that's a label that that you throw on somebody. So what we try to, what we call our incarcerated individual is residents. Like when they're in the community, when they're in prison, we call them residents, just to try to not, I think I was never a big fan of calling someone an inmate. Like that to me is like, it's a very harsh word, and offender too, and it just separates us from them versus, anyway, that's just too. So we're trying to change that label. But we try to do as much as we can while we house individuals and be as humane as possible with them, and take into account family reunification. And to that question too, what happens to those children? A lot of them, and this is just from personal experience, I want to just float that out there, not any statistical data that we have from our evaluation and compliance team who keeps track of all of our data. But a lot of them individuals, just from my personal experience, usually go to the next kinship. Usually grandparents are some that usually take care of the children, or sometimes, the father or the mother, whoever's not incarcerated, but a lot of the time it's grandparents. Sometimes it's aunts and uncles, and there are some that are adoptions. One of my most fondest and memories that I have, one of the things I'm the most proud of in my whole career with IDOC is we had an individual from Twin Falls, is where it was a male. He committed his crime in Twin Falls, and he was the sole caretaker of the kids. The mother wasn't in the picture, and health and welfare from Twin Falls contacted us and said, "Hey, there's this thing that we call, it's a goodbye meeting." And what they did is a health and welfare individual, as well as a health and welfare clinician, came over, and they brought the children, and they brought the adoptive parents into the institution. And I was the case manager of that individual, and we let them know, hey, this is what health and welfare wants to have this meeting where you basically give. It was very sad. Like there wasn't a dry room dry eyes in the room. Is where the dad got to tell his two children who were being adopted goodbye, and saying, hey, these are going to be the new people that are going to take care of you. Like, I trust them. You're going to be in good hands. I'm still here for you. Like, I love you, but I'm going to be gone for a very long time. So they're going to take care of you. And that was incredibly powerful. We also made sure that there was a clinician at the institution for the resident. So the little kids had a clinician there from health and welfare, and they drove all the way from Penn Falls to Boise, as well as we had a clinician there present during that time. And then we also did follow-ups, with the dad to make sure that he was doing okay. So it sounds like a small story, but it was like, to me, it was a very powerful story. And I tell it to as many people as I can, because that's one of the things that IDOC is doing. We're changing how we do things, and we're trying to do that more if we can, because I think that's like the right send off versus just, the parents losing custody of the children and not knowing what happens. So we tell other case managers, hey, if health and welfare or somebody else reaches out, we can do this. There's just, we have certain things and procedures we have to follow, but that's a possibility.
Tina and Jaime, thank you very much. Like those personal stories really shed light and provide a clearer picture for how this all relates to public health. And I just want to thank you, Jaime, too, is we're, being educated. The term using respectful, language is a critical component of public health, particularly as it relates to health equity. So just your guidance and advice on using the term resident has been extremely helpful for myself. I'm sure everyone here, because a lot of times you unknowingly offend people. What is the common language, right? Is it, inmate, it's like, and so, but just knowing the term resident, it's been immensely helpful. As a new mother, a relatively new mother, Dr. Neer here, and just you can, speak from both that kind of, I would just say just unparalleled perspective from that, connection between, mother and just her experience at Carceral, how that would, impact public health, at the individual level, community level. So I'll just stop there and just, give her the floor.
Yeah, I've worked a lot in parental incarceration and what happens to the children. And unfortunately, women are more likely than men, almost twice as likely to lose all guardianship to their children. And they're more likely to be the primary guardian. So a lot of those children do lose their parents in that instance, which is really unfortunate. But across the board, there's a lot of public health policies that we know we can implement that at a relatively low cost to really help these populations, such as reduced phone calls, access to different communication forms, emails, letters, placing mothers close to their children. Nationwide, it's known that we don't really pay attention to where the mother is getting placed in the carceral system, and more likely than not, it's a couple hours from where those children live. So even if they have visitation access, how many people can drive a couple hours for a 2-hour visit on a Saturday? It's really hard, especially when we want to think about all the disproportionately impacted families that are in the carceral system that we know about, such as low income. Women are more likely to not be able to pay bail. So if they can't pay bail, how do we think they can even communicate with their children? People of color, people with health problems, mental health, homelessness. So those children might have already been homeless. So how are they going to go get to see their parents? So I think there's a lot to think about from a public health standpoint, of how do we support the mother and the child, make sure they're both succeeding at life, because we also know children of parents that are incarcerated have higher issues with their academic success, are more likely to be aggressive in school, have higher health problems, are more likely to have asthma just because of their environmental factors. So there's a lot of different reasons that these two populations should be of the forefront of our thought process when thinking about how do we support them both.
And I think it's a really important point to make as you talk about kind of the mechanics of what happens to children when their parents are incarcerated. One of our deputy directors comes from a clinical background, and she has brought a lot of reading, like the female brain, the body keeps the score, the deepest well. Those types of academic reads educate staff about kind of trauma and what the effect of kind of those things are on the developing brain. And so I really appreciate the academic side that comes with our organization, and the emphasis and on knowing more and deeper about the needs of our resident population.
Absolutely.
And while we kind of have the mic, I just want to throw out, because we're talking about women right now, and I don't know how long we'll be on that topic, but we actually have what's called a coming home event or women's networking event the third Tuesday of every month at the Meridian library. It's actually on their little topic, but it all is about reentry and how can we support our women coming out of incarceration. And you would be amazed, we just have such a great community that really wants to come alongside folks. And so anyway, I invite you to that, or if you want to, I don't know if you want to put your email in the chat, and Desmond, I don't know if you can get those over to me or how that works, but love to send you that invite and just encourage people to come to that as to learn, and also just to, if you want to be a part of, what that looks like. So anyway, throwing that out there since we have the women talking about women.
And I will say we welcome conversations, critical conversations, like the question about why are so many women incarcerated. We don't stray away from the hard conversations, though. Those conversations make us better. And so forums like this are some of our favorites, right? The people that care about our population. We manage the population and we take care of them, but it takes community partnerships to really care for them when they get back out in the community. And I really appreciate you saying that. Like, I think the number is 93% or somewhere about that of the residents that are incarcerated will live in the community again. 98. Okay. 5%, okay, upward trend on something. But it's important to know, and we would be remiss if we didn't mention our staff, right? Using people first language is good for our staff as well, right? We hire staff that thinks about humanity and that think about changing lives and really believe that people can change. And so it's good for our staff to be able to be kind and come to work and believe in people. I think that when you look at, the prisons that are portrayed in the media and in movies in the past, that's not how we operate as a department. We hire people that genuinely believe that people can change.
Thank you so much for that. I don't even know where to begin. I think that we have so many comments here within the chat about, what would a dream partnership between public health and IDOC look like? And I think that we're, starting to find out some answers to that now. Absolutely, everyone who attends today, and Dana, we will definitely have an exchange of additional materials, and especially this third Tuesday of every month, that has been extremely helpful. So I think that we're right now in action, answering a lot of those, bridging those pathways right there. Also, in addition to the person first, language, and I'm thinking something else, perhaps just a toolkit and a guide how to refer, just like with that data, 98%, that's why we call them residents and community members, 98% of these individuals who are incarcerated who are going to be returning to our community, right? And they're just really changing, I don't want to say changing the narrative, but changing, I won't say changing, but just providing a correct interpretation of who our residents are and what a firmly incarcerated individual, looks like. I'm sure that because, like you stated, media and movies, an image comes to our minds, right, of what that individual may look like. But when you look like, oh wow, it's mostly women, the highest rate of women in the country, and then also data shows that these are individuals who are arrested for nonviolent offenders. Right, we have the highest rate of incarceration for nonviolent offenders. So, and also the highest rate for these individuals these are women with substance abuse issues, as opposed to being whatever image, comes to our mind. And, mothers, and we're looking about something that's familiar to our public health community, adverse childhood experiences, or ACEs. Just thinking about that, as a child seeing your parent or loved one, incarcerated, how that impacts social determinants of health. So, just a ton of great information here, just based upon what you've experienced and shared today. Best practices, right? What are the as far as we have the data on most individuals becoming return to the community, what are some of the best practices in ensuring that they stay in the community, reducing recidivism, and just improving public health outcomes, and just reducing that churning of once you're return to the community that you stay?
Yeah, so you're speaking specifically to like reentry, what has been promising, what are some best practices? Okay.
Yeah.
So
how do we speak that when they would return, we're not just releasing you back out, to the data shows if you're released to the same environment, the same structures, like, well, obviously you may be back. So how can we make sure that like individuals change, the circumstances, the factors change to keep these individuals within our community?
So just as we measure risk factors, we measure what's called protective factors, right? So what are the things going on in their life that are good in place? And so for one, just building on those strengths, Jaime mentioned the housing plan, for instance. If they have a significant other or someone they can go back to that's supportive of them, it's important for them to go there versus going to a transitional house. And so, if those protective factors are different for everyone. One of the main things that I'll say that we find is very promising is peer support. So peer support has shown to be hugely beneficial within our incarcerated individuals, because we do have a mentor program that occurs while they're in custody. And then we also have a Free to Succeed program where they get a mentor when they get out, that has also proven to be very successful. So peer support, and peer support looks many ways. We have 7 recovery centers as well across the state of Idaho. And so they have peer support and recovery coaches within those. So that has been a huge thing that has shown a lot of promise with reintegration, is just having that peer support. And most of that peer support is lived experience, right? So it's someone coming alongside that understands and knows what they've been through. So that's been one of those things of reintegration, and something that we've seen that's been pretty huge. Something I wanted to say earlier, but didn't quite get a chance to say because I forgot. It kind of goes back to how do you refer them to the, it was specific to reproductive clinics and so forth, but I just wanted to in general speak to some of the barriers that we face is being able to connect our residents when they get out and prior to getting out to an actual health provider. So that has been a huge barrier for us, maybe not being able to set up that appointment. A lot of housing or providers will not set an appointment prior to them getting out. And some of that has been just due to maybe they haven't showed in the past, or maybe that provider network has attempted to work with them, but they've just kind of been burnt, so to speak. And so that's been a huge thing that we've been working on within reentry, is bridging that gap with our community providers. Like I'll give an example. So Twin Falls, which is our District 5 area, we learned that their appointments weren't set out so far. So it was okay for them to report in. And then the clinician at that location would then set an appointment with their treatment provider. So that was just how that district wanted to do it, and it worked out well. In the Boise location, a lot of our providers are set out so far that 60 days of medication that Jaime talked about sometimes doesn't make them to that appointment to be set. So that's been one of the barriers. And when somebody said, you know, what's your dream relationship? Oh my gosh, I have like 20 million dream. Whoever wrote that question, reach out to me. Because I have about 20 dozen partnerships I'd like to do. But anyway, that's one of the huge ones, is just the health network and the partnerships within that health network. Because I think people want to come alongside our folks. It's just knowing maybe how to do that and how do we give them the best next step. I'll also say that St. Luke's did meet with us on several occasions regarding the pregnancy, the women having children while they're incarcerated. And so we did meet with them several times to figure out how can we do better. And so St. Luke's is one of those huge partnerships as well. So I think I rambled enough that I'm not sure if I answered the question either. So
these guys have done an outstanding job. And we have 1 minute left, but I do have 2 questions that I would like to perhaps get them done, combine them. Jaime, we've talked about how some of the unique social determinants and intersections of being, Hispanic and male here in Idaho. A lot of the work that I've, done in this intersectionality relates to, Black men and health and living in different environments. But that's, Idaho has a much higher population of Hispanic men, compared to Black men. So what are some of the unique, in your experience, some of the unique experiences and also tools and best practices that we can use for Hispanic men who, one, preventing involvement within our carceral system, but also returning to our community?
That's a hard question. So there's quite a few barriers too. And I think one of the challenges with a lot of the Hispanic population that we have is just how diverse the Hispanic population is. There's so many different countries that covers the Hispanic area. There's Mexico, which usually is the biggest portion of it, but there's also Central America, South America, there's Cuba, there's Dominican Republic, and they're very, very different than from each other. Their norms are very different too. They have different backgrounds. One of the big challenges that we have is sometimes they don't speak English, and their education, depending on where they're from, is a big challenge too. Is a lot of the time they only attended maybe grade school, so maybe like the equivalent of 4th or 5th grade. So they're reading it even in their own native language is very difficult. And so one of the things we try to overcome with that is we do have like a language line when we do offer services, whether it's the case management or the group facilitation. And one of the other things that we do also is we have some individuals that are going to be incarcerated for a long time. The ones, maybe 10 or 15 years that we develop relationship with, and that when we see that they're very trustworthy. So we also train them and we pay them to be interpreters. And so they can come to the classes, or they can come to different places where and interpret for the individual if they so choose. We just have to make sure that they're not the ones doing the homework, and training them for that. So that's one of the barriers. And one of the things that we try to do too is this is all pre-COVID. Now I want to go back. But pre-COVID, we did have a like for Hispanic Heritage Month, we had somebody from BSU. I got to find those old emails. And they came and they did a presentation. I can't remember what professor it was. And they came and they educated the Hispanic population. It was in Spanish, but it was in English. But they came and they provided some awesome things that different Hispanic leaders were doing. Like whether that was through their ancestry, whether it was Mayan or Aztec or Incan or whatever, as well as modern people that were of Hispanic descent that were being very successful. We tried hooking them, connecting them with some of those individuals too locally, some local business owners that were just targeting the Hispanic population a little bit more. But sadly, that has fallen, that went away with COVID, and I just thought about it now. So thank you, Desmond. And kind of the same thing with our Black population is they're also very different. Sometimes they're here. They've been from Idaho their whole life, or sometimes they're from an inner city, from like New York, Chicago, or for the South, and they're a very, very different culture and what they believe and how they act and what's acceptable, what's not. So also with them too. And then, and I'll be honest too, like when they become incarcerated, all that background that they had, if you're Hispanic or if you're Black, it goes away. And all that matters is that you're Black or that you're Hispanic, because they have that sense of we need to unify, and we need to look past our differences and look at the similarities that we do have, because they are the minority, here in Idaho, especially when they're incarcerated. Also with the Black population too, we do have a large percentage of refugees, that are Black, and then also they're very different too, and trying to help them and connect them with with resources that they know and that they're comfortable with. We have a decently large population from Sudan, that and they're very, very different in their own unique way. And trying to connect them and trying to find out. Sometimes what we end up doing is sending out emails. Hey, I have somebody from Sudan or from Kenya, from wherever, that nobody speaks their language. Does anyone have that? And then we respond to each other. Oh, I have somebody from that country that speaks that language. So then we get with our own like move coordinators or people that control the moves in the prisons. And we try to house those individuals together, and we'll let them know too. We'll be like, hey, there's somebody else that speaks your language, and that also falls too for the blind population. We have individuals that are blind and that are deaf, and just connecting them too, so that they have somebody to relate to. And I don't know if I answered your question, Desmond, but like it's just complex. Like they're affected in so many different ways.
So many different ways, and you touched on the concept. Thank you, Jaime. Hispanic, or it's not homogenous population. It's not all encompassing, as you mentioned, Puerto Rican, Dominican, Central America. Same with Black versus African American, right? Those are very, very different things. Unfortunately, guys, we're already 5 minutes over. So, but which is a great thing, because it just shows the engagement that we have. What I can assure you is that we will have a connection of resources that will be sent out for everyone who's registered after this call. So have no fear for that. But I would just like to close with a thank you to Dr. Neer, Jaime, Tina, and Dana. Thank you all for your active engagement and participation. And I definitely see this, to Dr. Save's point of how we're, that dream relationship between public health and IDOC. I think that we're took monumental strides towards establishing that here today. So thank you all. Please enjoy your afternoon, and we'll be following up soon.
Thank you very much.
Absolutely. Okay. Bye-bye.